Terrific. Thanks for having me here. And I bring everyone warm greetings from Dr. Karen DeSalvo, the National Coordinator from Health IT. In our group, we have a very strong commitment to support the growth and the training of medical students. And I think you may have already had an opportunity to see a webinar from one of our superstars, Dr. Kevin Larson. I believe his talk was about meaningful use. Now, I say that we're committed to your training, especially in the topic at hand, because of the absolute criticality of professionalism and leadership skills for the next generation of physicians. Now, I say critical because, you know, in our world of healthcare, amid decisions and discussions of electronic health records and interoperability, genomics and precision medicine, vaccinations and public health policy, connecting all of those discussions is the core concept of leadership. And while some have a natural gift for it, yes, for some, the requisite skills of leadership, they come very easily. We should never lose sight of the fact that leadership is a discipline that can be taught, studied, refined, and improved. And that's what I think the organizers of this series understand exceedingly well. Whether we're looking at the healthcare community regionally, in just one particular state, or nationally, one thing is clear. Time right now, in 2015, will always have been seen as a strategic point of inflection, and when leadership can make all the difference. Now, heard, or may know, I'm a surgeon, and I suffer from all of those vices, all of the vices of those virtues commonly attributed to surgeons. And in preparing for this presentation, I can't tell you how many well-meaning folks came to me to make sure that I didn't fall into my usual sales pitch to every student that I meet, that is trying to convince them to go into the most exciting, most professionally satisfying, and intellectually challenging of all the healing arts, surgery. So you should know that before I was allowed to speak to any of you today, I had to sign multiple very official agreements not to go on and on about the joy of surgery, the sublime joy of curing by the hand. I signed one paper that specifically forbid me from espousing the very well-known truth that surgeons are just internists who've been allowed to complete their training. And for the greater good, I agreed. So if and when any evaluations are made of this session, I do hope that all of you are able to confirm that I was a real team player and never, ever mentioned any of that stuff. That being said, the fact is that not all of my critical life lessons have come from my time in surgery or with other surgeons. Case in point, my definition of leadership. Well, I think that meeting your responsibilities, especially at strategic points of inflection, well, I think that's one of the best definitions of leadership that we can come up with. In 1963, Dr. Dunphy, a huge giant in the world of surgery, emphasized that if we as physicians are to keep our authority, moral, technical, scientific, then we must assiduously look to our responsibilities. And remember, they delegate authority, not responsibility, which is why I'm so pleased to talk to this group at this stage in your training to let you know that if you are to attain any leadership authority, you must be a prudent steward of your responsibilities in both your professional and personal lives. I pause right here because I take to heart some public speaking advice that my teenage daughter gave me years ago. She told me that if I'm ever to speak to young people, that I must be very clear and state my take-home messages early on, because she said, Dad, you have to bottom line your young audiences very early, because when you speak for more than 5 minutes, you become very boring and very tedious. So let me heed Dana's advice. Let me bottom line you with my take-home messages. Coming from ONC, it should be no surprise at all when I tell you that change is inevitable along with innovation. So you must know how to anticipate and embrace change. Next, and the key, you must appreciate that this work, the work that we do, is all and only about values and value. Such communication is both the path and the goal. It's like the practice of medicine, Communication is equal measure science and art. Given those two facts, no one here should be surprised that what we do is we engage in a team sport. Gone are the days of the lone cowboy physician. Any professional success you will have is wholly based on the strength of your team. And finally, I won't promise you all blood, sweat, toil, and tears. I can tell you that a successful path forward, your path forward, requires trust, character, and tremendous courage. So, we're at a strategic point of inflection. And in his book, Only the Paranoid Survive, Andy Grove, the former CEO and chair of the Intel Corporation, defined a strategic point of inflection as a time in the life of a business when its fundamentals are about to change. That change can mean an opportunity to rise to new heights, but it may just as likely signal the beginning of the end. Opportunity to rise to new heights, but for some, it just as likely signal the beginning of the end. Well, I hope it's no surprise to any of you here that healthcare has been approaching a strategic point of inflection. And several months ago, HS Secretary Sylvia Matthews Burwell confirmed it, a meeting with nearly 24 leaders where she set clear goals and a timeline for shifting the payment of medical services from volume to value. Now, at that time, she announced a goal of tying 85% of all traditional payments through quality or value by 2016 and 90% by 2018 through programs such as the Hospital Readmissions Reduction Program. Reducing or eliminating the untimely return of patients coming back into our hospital is usually done because of a failure to coordinate and communicate. That's become a major priority. Now, I'm not sure how many of you have ever heard of Dr. Barbara Mcclintock. She's a particular hero of mine, and I commend you to look up some of the details of her life and work. I'll summarize a bit of it for you. Barbara Mcclintock was a cytogeneticist who received her PhD in botany from Cornell in 1927. Specifically, her study led to an understanding of mobile genetic elements. Now, to medical students in 2015, the idea of genetic recombination is settled in old science, but in the early 1930s, it was poorly understood and far from settled. So when this rather short, introspective woman with a reclusive tendency began to challenge the accepted dogma of the time, well, she was dismissed. Prevailing assumptions were that, first, genetic material was fixed, and second, that science in general and genetics in particular was a field for men. So, working largely alone and rarely invited to share the results of her work, Dr. Mcclintock toiled away for years doing what would later be recognized back in 1983 by the Nobel Prize Committee as the most advanced and sophisticated research in the field of genetics. And she did this by studying maize. Well, at her Nobel laureate acceptance speech, she said something that was deeply profound and yet amazingly subtle, characteristic of her entire career. She told us that tacit assumptions held by the community, be that genes could not move or that women could not do important work in science. She said these assumptions were the substance of dogma and that they served as a barrier to effective communication. So, the relationship between Dr. Mcclintock's insight and the new payment models that I just talked about that were announced by Secretary Burwell. The connection is that the technical and social complexities of caring for patients today and in the future require, above all else, effective communication between you and your patients, you and their family, between you and other physicians and members of the care team. Tacit assumptions, that is, unspoken assumptions regarding others, what others understand, what information you actually have on hand, and what are the viable paths forward, are dogmatic barriers to treating disease and improving health. In short, today, a failure of effective communication can nullify the wizardry of gene therapy. It can render inconsequential the most proficient surgical procedure. It can do the best of intentions. And that's why health IT is such a stake in the open, the explicit, and the fulsome sharing of information. See, the open, regular, and robust exchange of information, whether it's between business partners or business competitors, that exchange, that's the lifeblood of excellent 21st century care and is the leverage point of value-based performance. Let that again. The open, regular, and robust exchange of information is the lifeblood of any value-based performance in healthcare. Now, we all know that even before the Secretary's announcement, we know that some communities have been actually struggling. And you have to understand that that struggle is not due to a lack of technology, but due to a lack of communication and in many cases, a lack of leadership. Because technology, it can be an innovation. They can be wonderful tools, a wonderful lever to facilitate the transfer of information and communication, and possibly even the transfer of knowledge. You see, in the right hands, at the right time, information can be transformative. Now, the full, complete, rapid, and regular exchange of medical information will represent a singular change in our culture. And can think of no better way to increase the value of healthcare services than to make their provision fully informed. That's the point of interoperability in health IT. That's the innovation that we'll desperately need and seek right now. And the fact is that you can't get any of that without trust and leadership. The thing is that the alternative is equally remarkable. Each of us in our own little silo, putting one new innovation on top of another with no real consideration of how one piece of information informs, supports, or confounds another. That means that we will keep our current haphazard and very dysfunctional method of taking care of patients. It means that we will recreate the experience of Babel. So, I hope you understand that while necessary, health IT and innovation is not the whole answer, because the question is not how much technology do we need. Now, I love this iconic Peter Bruegel painting. The well-known subject is a cautionary tale on many levels. And regardless of the cause, ultimately, the failure of this engineering project was a failure of communication and leadership. Regular and robust communication is essential for survival in any value-based performance initiative. It is the rate-limiting factor for the growth of an accountable care organization, or an ACO. And it will be the proximate cause of success or failure for any medical community in the near future. Now, this isn't sophistry or hyperbole. This is a fact of arithmetic certainty that's as clear as your admission orders or your organization's balance sheet. And the good news is that we actually have a roadmap to success, one that outlines three critical elements. First, requiring standards. At OC, we've created and will maintain an advisory of the best breed standards. Next, we're motivating the use of those standards through appropriate incentives. All of yourselves motivated now. And finally, we create an entrusted environment for the collecting, the sharing, and the using of health information. This is so important. You must find a way to build and maintain trust. And clearly, that starts with leadership. This is right here, the roadmap that we actually have created, and it has a lot of moving parts. This slide, believe it or not, is a high-level view of the critical actions needed for interoperability. Now, we can't and won't dive in even at this high level because our focus today, leadership, leadership, innovation, it actually transcends this detail. So let's look at a little bit of a simpler view of this. Now, this is an appropriate level for our purposes. Here you can see the keystones to interoperability success. Build on existing infrastructure, leverage the market, and focus on value. So you see empower individuals and simplify. And while I won't go over each of these areas, I have to direct your attention to the importance of privacy and security in the lower left corner. Clearly, privacy and security are rooted in trust. But beyond privacy and security, let's look at components. And the first among the most important, whether you work in a hospital, a large group, or in a solo practice. These two components, leveraging the market and focusing on value, are crucial. And let me stop a bit and talk a bit about physicians and value, because they weren't often considered together. But really ended back about 8 years ago when Michael Porter wrote this piece in JAMA. Now, I recommend this to all of you. It may be one of the most important pieces on American healthcare. He argues that improving the quality of care is the single greatest contribution physicians can bring to the movement of healthcare reform. The way we as physicians can regain our professional authority by honoring our responsibilities to the quality of our care. And I recommend this article to everyone, regardless of what lens you see the world, be it physician or payer or patient. It doesn't matter, because in it, Porter plainly declares that we must all be about the business of improving outcomes. So whether it's from the business end of a scalpel or a stethoscope, you should understand, again, that this entire grand endeavor is all and only about value and values. So to that end, Porter wasn't prescient, but he was attentive to the clear and consistent policy signals that we at Health and Human Services were giving, that in the 21st century, we are all about improving the quality of individual care and, by extension, population health outcomes, while increasing the efficiency and the transparency of healthcare. Many know or have heard of this as the triple aim. And this takes us to two more key principles: empower individuals and simplify. Now, the context of these two domains, simplifying and empowering individuals, they're usually thought to be about patients, caregivers, and perhaps consumers. And that's a very reasonable interpretation. But I always think that these can credibly be viewed as being about the needs of practicing physicians also. And to that end, I would like to focus on better communication around the usability of electronic health records. The software that we use needs to continue to advance with both a simpler interface design and improve efficient cognitive support. Now, that would really be empowerment, and every one of us should look to usability as our own responsibility, every one of us. So, to those of us on the front lines, that means that we have to really learn how to use this software. And when we find defects, we must give constructive feedback to the vendor, and must also amplify that feedback through professional organizations. And that also means that while we acknowledge the shortcomings of the technology, we must also be honest about the defects of the paper world that it replaced. The fact is that the profession you're about to join has always been hard. We stay late during paperwork, and we stay late at computer screens. I say that either is good. Inefficient when Osler was a resident, we were inefficient when I was a resident, and we are terribly inefficient now. So our inefficiency is not a valid reason to throw up our hands and quit this path of innovation in health IT. Now, having said that, I can say that electronic health vendors need to look to their responsibilities also. They must stop acting like the best screen layout that they can possibly design is a dead ringer for the hieroglyphics on Tutankhamun's pyramid. So that physician frustration today with EHRs is born from the fact that we find a lab value in 5 minutes, 8 clicks, and 6 screens on EHR, but we can order a latte from Starbucks and 2 books from Amazon in 30 seconds on our iPhone. As providers, we expect products no less than what we find as consumers. So, as a practicing physician, I will say to vendors, come on guys, you can step up your game. One way to start is signing on to the HIMSS, Electronic Health Record Association's Vendors Code of Conduct. Now, I don't know if you know this, but we actually have hundreds of EHR vendors. Only a few dozen have committed to a code of conduct that was completely crafted by EHR vendors. That the Dr. Dunphy, what did he say? We possess authority. We look to our responsibilities if we are to keep it. Now, usability is much more than mouse clicks. It's at the heart of our expectations regarding information technology and the very heart of how we as clinicians need help. For example, instead of warning me that the patient that I just ordered a cephalosporin on has a weak history of a penicillin allergy, help me keep track of all the women in my practice who have dysplasia on their pap smears. Tell me about the creatinine that may signal stage 3 renal failure before the patient's appointment this afternoon. Long before any meaningful EHR, when I was an intern and my chief of surgery asked me one time on morning rounds, he said, Dr. Hunt, what 2 diagnoses that you will never make? At time, the question actually baffled the heck out of me, and I briefly thought about just being silent and waiting for this question to roll away. But you all have learned early on that there are no rhetorical questions on surgical attending rounds. So I started to open my mouth to give some lame answer when the chief himself actually took me out of my misery. He said, you know, Dr. Hunt, 2 diagnoses that you will never make are the one you don't know about and the one you don't think about. Sure that I see the information that typically falls through the cracks, the things I don't know about when I should or that I don't think about. Now that is meaningful use, and as you begin your residencies and later when you enter into practice, make sure to insist that your EHR vendor will help you to actually do that. Let's finish up with a story about the power of leadership using cutting-edge technology to support a healthcare team and innovation to do amazing things. Now, this is a story that actually took place a while back. It was back in the 60s. Actually, it was the 1860s, and it involves 2 giants of surgery, Joseph Lister and Theo Roth. Now, Bill Roth was actually the equivalent of a modern-day rock star. He was, what is still actually the prototype of surgical leadership. As great as he was, any fair reading of the facts will justify why surgical history can be divided into 2 periods, that period before Lister and a period after Lister. Lister, as you may know, is the father of aseptic surgical technique. And you see that while leveraging this newly developed germ theory, Joseph Lister developed some methods that we use to this very day to prevent surgical infections. Here you can see improvement on his own rate of a common and incredibly lethal procedure, a below-knee amputation or a BKA. Now, this data is actually from Lister's clinic in 1866 and 1869, and is published in the British journal Lancet of that year, showing a marked reduction in operative mortality after a BKA. Mortality rate in the rest of the United Kingdom and in France, the home of Louis Pasteur, reflected the accepted standard of a 60 to 100% mortality after an amputation, almost always due to infection. Now, a remarkable surgeon took note of Lister's results and implemented a system that, within a few years, actually matched Lister's stunning reduction in mortality, and he did that nationwide throughout Germany. Bill Roth was so successful in antisepsis that Lister himself actually wrote Bill Roth to ask how he was able to do it. The answer was systems and leadership. Bill Roth was the chief of the Allgemeines Krankenhaus in Vienna. It was typical at that time in Germany. Surgeon-in-chief was also the chief executive for the hospital. So at Allgemeines, you had in the individual of Theodore Billroth someone with, one, the clinical expertise, two, he had the resources, and three, most important, he had courage to effect real change. Knew what to do and was important, and he had the authority and the courage to take responsibility and use this new technology to a stunning effect. More importantly, he had the most definitive manifestation of leadership. He was successful because his clinics were organized as an integrated system. Integrated system is the explanation for the German surgical miracle in the late 19th century, and there is no better cause for healthcare innovation than having integrated systems today, the 21st century. Now, before you all dismiss Bill Roth's wonderful results as the byproduct of an organized infrastructure and endless resources and time, let me point out that actually in 1870, the Germans took their unique systems approach to healthcare on the road. Now, I suspect that none of you will ever face 1/10 of the problems faced by combat surgeons in 1870. Yet, in light of war, leadership, chaos. Here is a wonderful case control where you will see the German results in the Franco-Prussian War as contrasted with those of the French in nearly identical situations because they were on the other side of that war at the Franco-Prussian battlefield. This is a graph of the importance of leadership with the appropriate use of technology. So I guess I really have two messages here today. At first, they really may seem a bit at odds. The message is that any truly successful innovation or technology in healthcare must exploit the incredible interconnectedness of our lives. It seems as though advances in healthcare bring greater clarity to the responsibilities of communication, the responsibility for honest, clear, effective communication. That has always been part and parcel of the authorities of those who care for the infirm. And the second message is that even with that wonderfully complicated interconnected dependency, or actually maybe because of that dependency, we teach and support the responsibilities of leadership with some mastery of own fates. That's why this group will work so very, very vital. So with that, I want to thank you all very much, and I'm hoping that we might actually have a bit of time for questions.
Hey, Dr. Hunt. I'm going to be unmuting everyone in a second. Okay. If you're all unmuted, you guys have any questions, please feel free.
Hello, Dr. Hunt. Can you hear me?
Yes.
Yes, I can.
Awesome. My name is Sheila Guillaume. I'm a second year medical student at Howard.
Wonderful.
I actually have two questions for you. Thank you so much for your presentation. That was insightful. The question I had was about the process of communicating with your vendors, because I'm curious, like, how does that work? Like, if you see a issue with your system, your health IT system, do you email them? Do you go through healthit.gov? Like, what's that process like to provide some constructive criticism, and also the turnover, like how long does it take to hear from them? And my question, my question has to do with practices that are not using health information technology, maybe in rural areas, etc. Because I can imagine, like you said, the goal of the secretary is to have the nation involved. So who is reaching to those practices who are not implementing the health system? And do you know of anybody who's in that situation? And I'm curious, like, what resources are available to them? Do they use, like, extension officers? Do people advocate for health IT through the website? I don't know. I'm just curious, like, who reaches out to those practices?
Two great questions. Thank you. Let me take them in order. The first thing is the question of, how exactly do you get this constructive feedback back to your vendor? Well, depending on your practice situation, if you're at a hospital, almost invariably there's been a team assigned, usually by the administration, to help with the implementation and rollout and the maintenance of the electronic health record. It's important to touch base with them when you see a flaw or an area that can be improved or some innovation that you really think will actually help with clinical care. And the reason it's important to get with that team is because one thing that many people have found is that at many pieces of software, the choices that you make in setting it up are some of the issues that many of the clinicians or providers take issue with. That is to say, many of the settings that you have where you individualize your screens, you decide on the layout, you decide on what information will be shared with what different clinicians, many times those choices are actually up to the people who actually install the software locally at your institution. So that's the first place that you should go. But as you can imagine, depending on the size of the bureaucracy, it may take a little bit of a real push to get them to listen. So you really have to make sure you work within the constraints of either your a local group, whether it's your department, your professional organization. Many times they'll have a committee for doing that. Now, for those of us who actually also see issues in our practice software in the office, it's a little bit of a different situation, because in some cases you have a large group, a large medical group that actually has the resources to hire health IT specialists that actually serve the same function as that administrative group in the hospital to organize and set up the functions. In that case, I would say I refer you to what we just talked about as far as with the hospital. That's not the case with most practices. Most medical practices, I think up to 60% of all medicine is practiced in outpatient clinics and offices that are actually 9 physicians or less. So we would say that's small practices. And for those practices, they don't have a big team that's involved with implementing it. Often it's one champion, maybe the medical director of the group or one of the people in the group who just know a little bit about computers who made those choices and settings. In that case, you almost always need to have a bit of a consultant that's in place. And there are many, many, many places where you can get technical assistance for that in how to set up your system and make those choices that might be local. And I'll talk about one of the key resources in just a bit, because it ties directly into your question about getting help for the rural physicians. Okay, but now you've exhausted or you've gone through the usual channels locally at your hospital or with the folks who set up your software in your office, and you still have this problem. You can also go to the vendor. Almost all vendor contracts has some form of help desk or user feedback. You give that information to them, and just like any user feedback, be it with Sony or any information technology or a technology company, you go through the prompts. It's a bit of a pain, but you go through. But you have to take the time to submit a request or a report. It's vitally important, and I'll tell you why. On the back end at ONC and at HHS, we actually take a look at how vendors are responding to users' complaints and whether or not there's a backlog of users' complaints in one particular area. So that's a long way of saying if you don't complain, we won't have anything to use to hold the feet of the vendors to the fire. So you have to submit that request, that help ticket, or offer that complaint. And also, you can go through your professional societies. If you're a resident, almost all of the residencies, all of the professional groups, whether at the American College of Physicians, the American Academy of Family Physicians, AAP for the pediatricians, the American Academy of Pediatrics, of course, the American College of Surgeons, all of them have residency organizations associated with them, and you can go and work with your professional organization there, and once you're out of residency, definitely work and submit and bring issues to the bear at the professional level also, because vendors tend to those issues as you collect problems that may begin to build up. They really have you can leverage the weight of your professional society to make those complaints. And then finally, yes, you can actually submit issues or send notes to us at healthit.gov. That's probably the slowest way to do it, because almost always, invariably, our first response would be a suggestion that you work directly with your vendor, but we do keep track of those. Those are some of the mechanisms that you have. And I'll be honest with you, as medical students, you guys are more involved with and working with technology than any of us old folk are. So you're probably a lot more familiar with how you actually get help from either Google or Facebook or anything like that. It's essentially in many ways the same. Now, the second question was about health IT in the rural communities, and it very much mirrors some of the issues and problems, not just in rural communities, actually mirrors some of the technical challenges in some urban areas that are underserved. So I'll sort of lump those two together. There are a number of excellent resources that are available to help small urban, underserved, or rural physicians actually implement and stay abreast of what they need as far as health IT is concerned. And those, I would first direct you to the regional extension centers. They were groups that were set up through the Office of the National Coordinator. They were available through many, many states. You can actually contact them also through perhaps a quality improvement organization. They would know where or how to contact your regional extension center. And the quality improvement organizations also often will have resources and help that will allow you to tie into that. There'll be all sorts of user groups and things of that nature available through those resources. The interesting thing is, and this is something that has baffled us, yes, areas and underserved communities have real challenges in implementing health IT, but the real joy and the exciting thing that we found with them is their challenges tend to be very discrete, technical challenges, mostly involved with getting good staff that can answer a few questions. But once they break through those questions and once they actually overcome those barriers, communities and those practices actually leapfrog over and get way ahead of people who are traditionally thought to be very wired or very health IT savvy. That is to say, some of the smallest and most back in the woods rural practices, once they get it right, oh my gosh, the results they can get because they're committed, they know their patients, and once they get their systems set up, they're absolutely phenomenal at implementing health IT. So I would say a number of resources. The Regional Extension Center program, you can actually also contact QIO to ask for where they might, because they often will know. That's QIO, that's Quality Improvement Organization. There's one in every state where you might be able to find help and resources for technical support. Also, I should mention, I talked a little bit about your professional society or professional organization. All of the major professional organizations also run help groups or have some resources available with helping their members actually overcome challenges with health IT. So the College of Surgeons, American College of Physicians, all of them, if you go to their resources, they'll be able to help also with that. The good news is that there's a tremendous amount of help around. And finally, and I shouldn't actually leave this out because it's not trivial, is that the group organization that actually sold you the software, be it if you had a direct contract with the vendor or if you went through what they call a value-added reseller, if someone actually you bought the software through someone who sells it and installs it, they actually should be your first line of help also with getting things set up. And they're the ones that are usually the first ones that the rural or underserved communities, they tend to be the lifelines. I hope that was helpful.
I'm sorry, I was trying to type as well.
Oh, no problem.
Awesome. Thank you so much. That helped a lot. Because moving forward, I just want to have an idea of what I'm going through. So that was awesome. Thank you.
Questions or thoughts, things that I had hoped I had hit on or that I missed, or any areas that you've seen that need further explanation, in particular in health IT? I wasn't a deaf. My daughter was right.
Is there another question? Yeah. You talked a lot about leadership and I guess reaching out. That was like one example. What I'm curious though, do you offer any training with that? Or have you noticed any training run there? Or is it, I guess, just that since you're a physician, you're already a leader? So I'm just curious if there's any formal training after residency, during residency, or to practice that for you to develop your leadership skills.
Well, yes, and again, you're in a real wonderful spot because you really have a number of opportunities that are available to you. And I'll ask you again to look to some of the very wonderful professional organizations that you're going to become a part of. Most all of you should think about becoming student affiliate members of both the American Medical Association and the National Medical Association. Those both have excellent programs helping to develop leadership skills and giving you opportunities at a relatively early age to take on some responsibilities of leadership. Also later when you well into your residency, again, all of whatever residency program you go into, whatever specialty you go into, there'll be a tremendous number of opportunities through your the core professional society. So if you're going into radiology or radiation oncology, the American College of Radiology is a great resource to begin and to look into leadership training. All of them desperately are looking to train the new generation of leaders because it's very, very clear that is probably our only path to salvation as a profession. So I would say look to our wonderful professional societies. And you can, again, start with the student groups at both the American Medical Association and the National Medical Association.
Awesome.
Okay.
I have a question from LaToya. She's currently in a space where she can't speak, so she typed a question out for you.
Sure.
And I saw that you went to Howard Medical School as well, and that you were a professor here. She's actually a second year at Howard. Next year and start clinical rotations and get exposed to EHR for the first time. What are some tips for students using EHR?
That's a great question. People will think it's a setup because we're both from Howard, but it's not. That's a fantastic question. One of the first things that you can do to begin is to find out which EHR you actually have in your institution. If you're starting your clinical rotations, find out which EHR that you actually have, and almost all of them have a tremendous wealth of information on how to use it and how to actually work with it. So I would start with usually the online information that they have. Now, most systems, particularly hospital systems, will have a training program. Some of the best and most well integrated systems have a training program that can be anywhere from a few days or weeks course to even longer on how to actually use the EHR and the health IT. One thing that I'm going to hopefully try to talk with the group over at Howard specifically about is with Dr. Deborah Ford, who runs the Simulation Center, is to be able to have simulation training actually on some of the electronic health records also. If any of you are at Howard and haven't had a chance to work in the Simulation Center, I think that's got to be one of your first steps also. So to go back to sort of recap my answer is, one, find out from whoever is the administrator in your hospital who oversees the running of the health IT, and often it's the biomedical informatics group or maybe a committee or a group associated with it, and they'll be able to tap you into a tremendous amount of literature. I can't overemphasize how important it is to read how to use the software itself. Unfortunately, many pieces of the software are not nearly as intuitive as some of the things that you typically will use online, like Google or Facebook or any of the iPhone apps. So you have to actually read some of the documentation. And I think many of you who have become very facile at some of those softwares that I just mentioned will also find that it's very, very useful to just read some of the help screens and learn how to use it also. But get used to actually doing it. Many of the programs, as I said, in the hospitals will have a simulation center or a training program. I highly recommend that. Now, it's very important that you begin to understand how to use the flavor of EHR that you have at whatever institution you're in. When you go to different hospitals on different rotations, unfortunately, or fortunately, I'm not sure which it is, you'll have to actually recreate that same process again, because in many cases, like for example, say I'm going to just use the Washington metropolitan area as an example. Say you're on your rotation at Howard University Hospital and they may have a system that's run set up by Epic. You may go over to another hospital, let's say Providence Hospital. You may use a Cerner system. So wherever you go on a rotation, expect to have a brief introduction on some of the ins and outs of how to use the software, but the best place to go is the biomedical informatics department at the institution. Even if they're not running it, they'll know exactly who you can contact to do it. And once you find out which system you have, be it Cerner or Epic or NextGen, whatever vendor is, there's a wealth or treasure trove of information on how to use it, just as there is with virtually any technology today. If you have a Sony high-definition camcorder, believe me, you can go online, find out how to use the instruction manual or how to find the instruction manual for that online. use your skills that you've already honed pretty well for other areas to find out how to use this. But it's important to actually read the manuals and get training.
Thank you. She has
my pleasure.
Question as well. Have you participated in telemedicine, and can you describe your experiences with telemedicine?
Telemedicine is absolutely fantastic. Now, I haven't, as a clinician, actually done any practicing with telemedicine, but one time, it's been a few years back, I had an opportunity to actually go and visit a bunch of some of the most far-flung Native Alaskan and tribal clinics up in Alaska. And each of those tribal clinics, surprisingly, they were run through, they were administered through the Indian Health Service. Each of them actually was well fitted with health IT. They had electronic health, had an EHR that they used, and virtually every one of them, if you can believe this, in the most far-flung place of Alaska, had telemedicine capability. And what I saw there was absolutely phenomenal. So, for example, say you have kids in far-flung place in the middle of rural Alaska that have recurrent otitis and actually need laryngotomy tubes, say, place. So they'll actually travel pretty far, typically to a large tertiary medical center like maybe in Anchorage or Juneau or some place like that, to have their laryngotomy tubes placed. Now, after the initial post-op visit, they'll go back home, and every few weeks or so, they'll need to have a check on those tubes. That check can actually be done by telemedicine. That is to say, the local clinic, while they don't have a ENT, and many times they may not even have an actual physician, they may actually have either a physician's assistant or maybe a nurse nurse practitioner there. They can actually connect teleotoscope, an internet-connected otoscope, so you can have the visual checks of the laryngotomy tubes done by telemedicine. Telemedicine is an absolutely wonderful technology, and we've not even begun to dust off some of the real applications on it. Now, and that said, I don't want any of you to think, and this is a very important thing for you, particularly as medical students, to get a hold of. Seneca years ago said, and William Osler copied, repeated this, medicine is a hands-on sport. You have to be able to feel the pulse, okay? Don't ever believe that any technology in between you and your patient is the best way to go. Optimally, you always want to have face-to-face, but when you can't, telemedicine is a tremendous way to do it. One of the things that we started to really explore, particularly with our defects in mental health care, is the idea that you can have mental health visits. So while the initial visit, the initial consultation with, say, a psychiatrist, so you have a child who may be suffering from depression or any number of mental illnesses, the initial consultation can be done actually in a face-to-face situation, and probably should be. Many of the follow-up visits and the check-ins can be done by way of telemedicine. Dermatology, another fantastic area, particularly in areas in fields and specialties where you have shortage of professionals. Again, my visits up in rural Alaska, they have a tremendous, huge telemedicine dermatology referral center. Very few, as you can imagine, dermatologists out in the field in far-flung Alaska. All of them are located typically around Anchorage, and many of them have clinics. And if any of you have had already a dermatology rotation, you'll know that you look at the rash and you look at the condition with the high-def cameras, and you take a history, and you can do, I would say, in many cases, almost 90% of dermatologic visits visit and follow-up with telemedicine. So we've just begun to scratch the surface of it. But the most important thing, I would say, with this technology is that you have a good appreciation of when it is not appropriate. Okay, and that's true throughout all of your medical careers. You know, you're going to learn a lot of techniques, you're going to learn a lot of indications, you're going to learn a lot of different things. And the thing that's most important that you learn is when it is not appropriate to actually use a technique, a modality, or a particular treatment. The most important pedal in a car is the brake, okay? Because our first objective with everything is to do no harm. So it is very important that if you engage with any technology, be it telemedicine, EHRs, some of the new Da Vinci robotic surgical procedures that you have, it is most important not that you learn the indications, because of course everyone always learns those. Learn what are the contraindications and learn when you realize that you reach the absolute limit on what you can do with this technology, because no matter what, the standard of care should always be excellence, regardless of whether you're doing telemedicine 800 to a clinic 800 miles away, or you can actually reach across the table and touch a patient. So to that end, I would say, and I would always, most of my examples, as you probably heard, involve some form of surgical relationship. So I would say an acute abdomen, you can't do it with telemedicine. You just can't. You got to be able to palpate the abdomen. You got to be able to auscultate it. So there are many things that you can and that you can't do telemedicine, but we've really just begun to scratch the surface. And I think that in your early careers right now, you're going to probably be using and seeing more and more telemedicine applications than I ever did.
Think that we should probably wrap it up. We're about an hour. Did you want to have any closing words before we close out?
Well, the big thing I want to say is I want to thank all of you for your time. I really appreciate the questions that you have, and I appreciate the energy that you bring to this. For those of you who are early on in your years in medical school, please remember that there are opportunities almost at every stage in your postgraduate training for internships and fellowships, even briefly, or clinical rotations in not just in the hospitals, but also in places like ONC and other areas of the federal government. There's a wonderful program at NIH called the COSTEP program, where it's a commissioned officer training program. They're great for summer rotations if you're a freshman year or sophomore year and actually have some time off during the summer. Almost all of them, they pay very, very well. So please remember and think about us in the federal government also for opportunities for some of your extra training. Later, when you don't have the time for a whole summer, you may be able to look at and ask about month-long rotations or elective rotations through us. Even we've had interns, actually, medical interns who will have a rotation come to us. So please remember the federal government in general, and many of us in HHS and ONC, if you have an inclination or interest in health IT, I think you'll be able to get a really good rotation, and it'll augment your training tremendously. If I just make a pitch. And I guess finally, even though I said I wouldn't do it, all of you really need to think about going into surgery.
Medicine.
Okay, fair enough.
Dr. Hunt.
Thank you.